Thanks so much, everyone, for watching. We've got an epic lineup tonight of speakers. We've got an awesome panel here. Amazing group of functional doctors, technology, activists for a leap forward in medicine.
You know, our goal is to make it easy for practitioners to learn in community.
This ecosystem that is being set up by the meetup groups, we believe will be the future ecosystem of this evolved primary care network, and it all revolves around you.
Welcome to the Functional Forum. Thanks for joining us in the charge to accelerate the evolution of medicine. Please welcome your host, James Maskell.
Hello, everyone. Welcome to the Functional Forum. Great to have you on here tonight. Super excited about our show tonight. We're going to be talking about deprescribing and drug-induced nutrient depletion. Could it be a more important topic for physicians and providers alike as we chart the future of medicine? We are live tonight, so you can ask questions. If you go to Twitter and you make a tweet with hashtag Functional Forum, I'll find it and I can bring it to the guests that we have on here tonight. So without further ado, let me introduce those guests. We have two incredible women here who are on the front lines of health creation. We are here with nurse practitioner Dani Williamson. Welcome, Dani. Great to have you here on the show.
Great to be here. It's been a long time coming.
Yeah,
That's
exactly. Right. Snap. And then we have Kirsty Washam, who is a clinical pharmacist and knows all about polypharmacy and deprescribing, and we're going to get into it. And if you want to follow Kirsty, you can go and check her out on Instagram as the Fed-Up Pharmacist. I think that's how we connected first. So why don't I start with you, Kirsty? What are you so fed up about?
You know, where to begin? I think the biggest thing I'm fed up with is just the sheer volume of prescription medications that I see patients on a daily basis. I'm in the South, so a very high population of overweight, obese patients with a lot of comorbidities like diabetes and hypertension, high cholesterol. And it's not uncommon that in my practice in a hospital, that I'll see patients on up to 40 medications a month.
Wow, 40 medications at one time.
That's polypharmacy, like the definition of polypharmacy right there.
Wow. Yeah, so how does that even happen?
That's a great question. So, you know, the majority of patients are seeing multiple providers now. We no longer go just to one physician, right, for our needs. Medicine's been divvied up, and so now patients have all these specialists. So they have their primary care physician, they've got their cardiologist, they've got their endocrinologist, and so we're just stacking specialists and medications one on top of the other, and no one is really stopping in a 15-minute appointment that a patient has maybe twice a year with their physician. No one's stopping to take the time to really comb through these exhaustive lists of medications that people have. Because it's time consuming, right? And it takes an eye for that.
So what sort of role is there, like a clinical pharmacist like yourself who is tasked with that? And in what sort of organizations is there someone with that job?
Sure. So the majority of hospitals now do have clinical pharmacists such as myself in roles specifically geared towards something called medication reconciliation. So that is a pharmacist looking at medications in what we call transitions of care, right? So as patients are coming into hospital, being admitted, they're being reviewed. And then as patients are being discharged from the hospital, it's another transition of care, as we call it. And their medications are being reviewed at that point also for just appropriateness. It's huge.
So Dani, let's come to you. So I know, you're sort of on the other end of it, right? Where you have patients who are coming in, and I'd imagine some of them are keen on getting some deprescribing themselves. That's maybe why they're coming to a functional medicine trained nurse practitioner in the South.
You bet. And that's what I see all day, every day, are those patients that come in with 20, 30 prescriptions, although I am functional medicine. So I do tend to get the ones that seem to be a little bit healthier, but I'm in the South as well. I'm in Tennessee, Kirsty's in Kentucky. And, that's exactly what we get. Now, I focus on autoimmune. I get the sickest of autoimmune patients in the office. And We are weaning down daily on benzodiazepines and antidepressants and you name it, NSAIDs and birth control, things like that. So yeah, we work, and Kirsty and I work hand in hand with lots of things. But yes, we get the same patients.
So let me ask you this. So when you see a patient and you're able to like de-prescribe them, you know, either because you're reconciling, you know, their prescriptions, or they're getting healthier and they don't need it as much, you know, how do those kind of conversations then go with the sort of the rest of the medical profession, who are obviously very clear that the patient needed that?
Well, they don't go very smoothly in the South. I can only speak for the South. I cannot speak for the rest of the country, but they don't go very smoothly. Although today, I got a brand new patient today sent in from an endocrinologist, and the patient wanted to try something different. And she was sent to me today. I hadn't even told you that, Kirsty, today, from the endocrinologist. She said, you need to go see Dani Williamson. She's the one who can help you come down on this thyroid medicine. So as a rule, it doesn't go over very well. So there's not a whole lot of crosstalk between the providers, not at all. And they're not interested, honestly, in what a nurse practitioner who has stepped out of the box and is now working with root cause medicine, who stepped out of allopathic medicine. They're not interested at all, really, in what I have to say about it. So they generally don't return phone calls. That's how it goes. So I do what I do, and our patients get better, and we start weaning down on things, and, you know, their heartburn starts getting better, and we wean off the Nexium, and we go from there by managing, by, you know, addressing root cause issues. What happened that caused that migraine, or that high blood pressure, or that diabetes, or joint pain, or heartburn, etc.
Absolutely. Yeah. So, Kirsty, I think you have some statistics here on like sort of just the level of polypharmacy that's happening in America and in that patient population. Can you take us into that for a moment?
Yeah, I wrote some stuff down earlier. So, you know, I saw a quote when I was kind of researching for this that said, "De-prescribing is good prescribing."
Yeah, that's great.
Isn't that great? And so what we see happening, what Dani can, you know, speaking to earlier, is that with these patients and all these medicines, we get into this pill for every ill trap, right? It's this vicious cycle. And at some point, we're prescribing medications because of the side effects of other medications. And I'm excited to talk about that later, as far as like how that goes along with drug-induced nutrient depletions. But yeah, some stats, let's see. So de-prescribing. Now, this was in patients who are in like nursing homes, but de-prescribing can reduce the risk of hospitalization by 36%.
Wow.
And the risk of death by 26 to 38%. Now, that's a specific niche, you know, group of like your elderly or frail patients, but that's significant.
Yeah.
And then in the ambulatory setting, so that's what a lot of us are in, right? Can decrease mortality by 26%.
Unbelievable. Yeah.
So we know that medications, right? I mean, even well-prescribed medications are can be harmful. Like all medications can have side effects. So, and we don't have studies showing how 30-something medications work together. We don't have safety data on that. No one studied that.
No, and I had a stat from Susie Cohen from Drug Muggers from years ago. At least half of all the drugs prescribed in the United States commonly deplete specific nutrients. Mm-hmm. At least half of them.
Right.
Isn't that amazing? My mom's in assisted living. She has Alzheimer's. She's on, I don't know how many medications, you know, and was having leg twitches and all kinds of things. She wasn't on one supplement, and she was on 2 different Alzheimer's medications and and Cymbalta and Prozac and just multiple things. And we started her on a little bit of magnesium and some B6 and some B12. No more twitches, no more she almost had like a serotonin syndrome effect, you know, and this constant jerking. Yeah, at least half of the pharmaceuticals in the country deplete.
Well, we're going to get into that, and I'm really excited here today to talk a little bit about not only drug nutrient depletion, and we'll get into that as we go along, But also one of the things that I know that you guys are really passionate about and we'll talk about is the effect on the microbiome. But let's leave that for a minute. I want to pull up something for you guys to look at. So this is actually from a presentation I was giving last week. And on the left-hand side here, this was from Nature 2015. And it was called Imprecision Medicine. And I think I was at like a PLMI event when Jeff Bland put it up there. And they says, for every person that they do help, and that's the black or the blue people here, the 10 highest grossing drugs in the United States fail to improve the conditions of between 3 and 24 people. So, the reason why this is really important is because pharmaceutical companies generally use all sorts of tricks to try and show people that what they're doing is more valuable. And they use things that, those of us who are familiar with it, you saw in the pandemic too, like, relative risk ratios and absolute risk ratios. Ultimately, though, the question that you want to know is how many, if 10 people come into my office and they all have, autoimmune condition, and I give them all Humira, how many are going to get better from that? And you can see here, Humira is 1 in 4. So that's a drug that costs, $5,000 a pop. That's 1 in 4. I mean, Dani, you said you treat a lot of autoimmune disease. Obviously, there's downstream effects of taking Humira for any period of time because it's kind of turning down the immune system. But when I saw this here, I mean, you can just look at Abilify 1 in 5, Nexium's like 1 in 24, Crestor's 1 in 20. You look at these numbers, Remicade. I mean, these are serious drugs that have been used all across the country. It seems crazy that this is like the first port of call for most people in healthcare when we know what we know.
Right. Well,
we
that's
know
where the
what
money
we
is,
know.
right? That's where the money is.
Yeah.
Well,
And, like, these are expensive. These 9 drugs cost a lot of money.
Yeah.
Yeah.
And to your point, Dani, like most people don't know, and obviously that's the purpose of like getting the word out about functional medicine. And you see all those books that have been right behind you. I know you've written your own book as well, right? To try and get the word out to say, hey,
right.
There's more options here.
And they don't know, and I, as a nurse practitioner, went to a fantastic school. I was not taught that there's a root cause for everything that we have going on. For me, it was, I have lupus and irritable bowel syndrome and chronic itching. I was never taught in school there's a root cause for your patient's lupus. She wasn't born with lupus. Figure out what the root cause is. And, so these healthcare providers, they weren't taught that. But unlike Kirsty and I and you, they've never stepped out of the box to learn anything differently. Ever. I mean, they haven't. Now, your people have, the people that are watching, but our traditional, you asked, how do the other providers, react to de-prescribing and all? Well, they don't react well because they don't even understand. They treat symptoms every day. Right, Kirsty?
Yeah.
I mean, the only providers, since we can speak frankly about this because we're addressing other provider groups, the only providers I've seen who are even more open-minded tend to be your osteopathic trained physicians. They do tend to be a little, and Dani's son's actually in DO school, but they do tend to be a little bit more open-minded as far as de-prescribing and hesitant. I shouldn't say hesitant, but less eager to prescribe medication to address an issue when there's something else that could be done.
Right.
Absolutely.
And they also don't have the time. You mentioned it. They've got 5-6 minutes, as a functional medicine provider, have an hour and a half with my new patients and 30 minutes with my follow-ups. And they don't have the time to tease this out.
Yeah.
Well, where's the money coming from? It's coming from the insurance company who's paying them for ICD-10 codes and the medications that their patients are adherent to.
Absolutely. Well, look, before we get into the microbiome stuff, I guess, one of the things that's happened in the last couple of years is we've seen a lot of doctors sort of make their way to try and learn some of these things, right? When you look at the data of, let's say, vitamin D And COVID, you know, you don't have to look at too many of those papers to think, man, I should really like learn about that, because it seems like it's having a big effect on my patients' resilience. So we've seen a lot of doctors coming this direction. I've heard it from the supplement companies. I've heard it from the education companies. You know, I've seen it, you know, myself, and even some of the work that we're doing to try and get doctors to embrace lifestyle medicine, the systems to embrace lifestyle medicine. I'd love it. I don't know if either of you could comment on this or if you understand, but you know, in the same way that COVID, you know, made the chronic acute, right? So, you know, you could live your life with your chronic condition for a long time, and then suddenly COVID comes along, and something that was like, well, it might, you know, only reduce my time of life at the end of my life, or my quality of life at the end of their life. Suddenly it was an acute issue, because it's like, me having a chronic illness today is massively increasing my chance of dying today from this, you know, from this new virus. And I guess, what sort of extra risk is put on patients if they're on 40 medications for an acute infection?
Kirsty.
Well, as someone who has spent the last 2.5 years inside a hospital,
Yes.
I can tell you firsthand that regardless of what, can I speak very frankly, James? Can I just
Sure.
lay this out there?
Yeah.
Okay. So regardless of what the media is telling people, that this is an illness that is deadly and detrimental to anyone, regardless of their health history, that's not what I saw. I didn't see a single patient who was healthy in that hospital. Not a single one. Didn't see a single patient who was healthy die. Multiple comorbidities, obesity, all the things that we as functional medicine providers know, like underlying inflammation, like chronic inflammation. No one was even looking at inflammation or vitamin D levels. No one was paying any attention to that stuff. And still, even towards the end, no one was paying attention to it.
Nope.
So
No, they're not.
No.
Well, yeah, I mean, I'm glad. I mean, I think everyone, you know, well, people in our world know that. I guess I feel like, you know, that COVID did a lot to make the chronic acute, made it sort of really clear to people that there was a bigger problem than just having a chronic illness. You know, it was a deathly issue. And the reason why I ask is that, you know, there are other countries that are as close to being as unhealthy as America, right? England is almost as unhealthy as America. But even in England, the level of prescribing is way lower. And so like somehow we have to kind of piecemeal and sort of piece apart, why did so many Americans die in the pandemic compared to other countries, you know, in that way. And I guess, you know, part of the thing that we talked about early on was just that being on certain medications is going to mess with the receptors. And ultimately, you know, that there may be 1 or 2 medications that just by luck, you know, might help. But in general, you know, being in a state of polypharmacy is going to make you irresilient to an external threat.
You bet it is.
I mean, you think about medications just by default had to be eliminated some way, right? So whether that's hepatically, renally eliminated, and that's what we were seeing these patients, you know, problems with renal function. So just multiple organ failure and in an already stressed system.
Well,
no margin for error.
No margin for error. Exactly. And no margin being empowered. And so I think that was a frustrating thing to me, is that, you know, you said like the chronic became acute, and it certainly did, but these physicians weren't letting these patients know that, hey, because you have these underlying chronic conditions, you really need to take these precautions, with the exception of like the one precaution that they wanted everyone to take. But they weren't empowering the patients to take control of their lifestyle and these diseases, because they don't believe, and they weren't trained to believe that those conditions can be turned around. Like what Dani does in her practice, like what we see happen, that you can take type 2 diabetes and you can reverse that. Now, you may not be able to reverse all the damage if you've had it for years, you know, but you can reverse it. You can take autoimmunity and you can be reversed.
That's exactly right.
Absolutely. Yeah. Well, look, I want to get into that. And I'm glad you actually brought up type 2 diabetes, because actually in that same presentation that I gave, I'm going to bring it up here because, why not? I actually been giving this presentation pretty regularly recently, and this is Dr. David Unwin in the UK. So this is a guy who realizes that type 2 diabetes can be reversed and wants to de-prescribe people off. And this is the data. This is actually from the British Medical Journal earlier this year that shows the number of people. He created a program to get people into groups and have them reverse their type 2 diabetes together. And what this shows is that program, which is essentially like low carb plus community support. I mean, that's really what he's doing there. He's been able to reverse. If you look at these numbers here, you'll see the number of patients that he has in his clinic that have type 2 diabetes. So that's, you can see those numbers here. I mean, it's a decent percentage of his whole clinic, because obviously, the numbers are going up. You see the numbers are going
every
up
year,
5 years, right? But then you can see the percentage, the number of people that have actually chosen his approach of doing something totally different, which is really focusing on doing healthy behaviors and being in the group. You see the number of choosing it, and then the number of remissions. So these are the number of people that have actually reversed their type 2 diabetes by lifestyle in his practice. And then when you look at it, it's now up to 22% of the clinic. So the reason I bring this up is because this is de-prescribing at a serious level. This is not just, one here and there doing it. This is being able to be tracked. Dr. Unwin was 2016 NHS Innovator of the Year and is now looking to sort of scale it up. And this next slide actually is really powerful because it shows you the amount of money that was saved on medication. Now in the UK, obviously there's a single payer system, and so the government's paying for all of it. And he reckons that if you were to take this approach and this approach saved £70,000 just of type 2 diabetes medication, metformin, insulin. That's all that they were calculating. If you had more of a global number in savings, like saving the people who also had COPD, also had heart disease, also had anxiety, also had depression, it'd be much more than this. But just with this one number, you're able to see that, they save £70,000. He reckons that this, you can see now, this is the medication spend as compared to other clinics in the area that don't do this at all. And you see how much money it could save. He reckons that just this one medication alone, they could save £270 million a year. It's almost £250 million. And all that is getting a few type 2 diabetes patients in each practice, putting them in groups and having them eat differently. Yeah. And so I wasn't expecting to share this, but this is from another presentation I've been giving. But, what it really shows, which I liked, is like what is possible when you sort of implement this all the way through a system, and that you can actually see it's not small numbers, right? It's over 100 people that have reversed their type 2 diabetes.
And that's not even in a disease state that we would typically think of de-prescribing in.
That's right.
So
you're right about that.
When I think about de-prescribing, I generally think about usually psychiatric medications would be the first to go. Things that are centrally acting, things that would make a patient fall or, at risk for a fall. So benzodiazepines, antipsychotics, things like that. But that's phenomenal. Like that's really
incredible.
Great. It is.
Well, he did it by helping them control what's at the end of their fork.
Yes.
Right. Changing their diet, getting them in community. You heal when you have community. It's the entire last chapter of the book. It's my 6th step to healing. But when someone says to you, what are you, Dan? Well, for me, it was 24 years of seeing doctors, 10 doctors, 4 colonoscopies before a doctor ever leaned into me and said, Dani, what are you eating? Don't you know your diet controls your symptoms? And it went from there. I mean, I didn't have a group setting, but amen to him. Good for him.
Good.
It works. When you control what's at the end of your fork, when you heal the gut, you change the entire trajectory of your life. And that's what happened to me 12 years ago. And in turn, it's changed the entire trajectory of thousands of patients' lives. Hopefully my children's lives, my grandchildren's lives as well. When you learn that your body is designed to heal itself, you just need to give it what it needs.
So just give us some tips then before we move on to the next part of the conversation. So you want to get people off medication. Obviously, you need someone who's going to sort of look at all of them, and that's kind of the role that you play, Kirsty. But like in the act of de-prescribing, let's say over a period of time, what are the things that you guys recommend in your practice that can facilitate that? Obviously diet is one part, but what are some of the other keys?
Well, I can speak to that one real quick before she speaks, because that's exactly what I do with the steps I use. Eat well, sleep well, move well, poop well, de-stress well, and cultivate community well. You will never de-prescribe successfully if you're not eating well or sleeping well. Your patients that don't sleep well are not going to eat well. They certainly are not going to exercise well and move their body. They're not going to poop well. Their stress levels are going to be higher. So it's all connected with those steps for me. You can't just start weaning people down on benzos or antidepressants without getting those other things. If their stress levels through the roof, well, then you're not ever going to get them down off of their antidepressant or their benzodiazepine. And if they're not sleeping, you never will, because they don't feel good enough to eat well or move well. So we work all connected like that. It's our 6 steps that we work with. That's what I see. What about you, Kirsty?
Yeah, I think that goes back to just communication, right? Between the patient and their provider, and shared decision making. Western medicine specifically is, I think I just saw an article in New York Times posted about medical gaslighting, right? Like physicians not listening to their patients. And so it's a two-way street. It's not the physician just deciding, well, this is evidence-based medicine, this is XYZ, what we need to prescribe for you, because this is what is going to get me a paycheck at the end of the day, right? And check all the boxes. But it's really between the patient and the provider, like having an open line of communication to where they feel heard. And I think that's the way we get these things to happen.
Beautiful.
You bet.
Cool. Well, look, I want to give a quick shout out before we go into the next segment to, some of the sponsors that we have here at the Functional Forum, and just, one topic that's just hot in this exact moment right now is, one of our group sponsors, Heal Community, something that I've been working on here for a couple of years, to be able to deliver like what you're talking about, Dani, there, to be able to deliver that inside the payer system where doctors don't have to go through a whole, education, re-education. My feeling from speaking to a lot of doctors, Dani, is that even though most of them don't understand functional medicine, don't understand systems biology, don't understand supplements, don't understand root cause approach, they know that their patients should be doing those things. They just don't really have like a framework for setting it up. And I'm really glad you said what you said. And it was very elegantly said in that, it's really about doing those fundamentals consistently. And if we could do those fundamentals consistently, you can start to open up, new opportunities for de-prescribing. But thanks to all the sponsors that make the show possible. I'm super grateful for them. And I want to just give a shout out, particularly for Heal Community, because we're in the business of that all day, every day. And it's really exciting to sort of be easing that flow. So look, the next thing I want to talk to you about, so the reason why this ended up going down like this and me getting you guys on is because I was perusing an upcoming conference, which is the Functional Medicine Pharmacy Symposium, which I actually went to the last 2 years because I just feel like this is the most important topic in medicine and no one really talking about it. And I feel like the pharmacist actually has kind of a key role because they can, look at different medications and decide which ones that people can go off on. And if what you said was true earlier, Kirsty, with those numbers, which I have no reason to believe it's not, this is a critical thing that we need to be doing. And I saw your talk and I was really interested in it because we've talked a lot about drug-induced nutrient depletion, and we could talk about specific drugs here in a minute, but your talk was on the microbiome and this sort of, if you've been watching the Functional Forum over the years, you realize that the microbiome is this like incredible mediator that's mediating so many processes in the body. And, we're just starting to understand the complexity. But, I guess a thing that we've never talked about on the forum is what are the drugs doing to the microbiome? And then what are the knock-on effects of that? So, where can we start with that? Because I really want the audience to really get their head around this mechanism, because it's not just nutrient depletion. And we'll talk about the nutrient depletion side. We've talked about it quite a lot. It's super interesting, and I think there's a lot that we can get from it. But I really want to talk about the microbiome and the disruption from the medications.
Sure.
Yeah, go for it.
Start. Well, I want to start with what Jeff Thurston said. My good friend, Jeff Thurston, who is a brilliant microbiologist, said to Kirsty and I last weekend, and I'm going to quote it. So we're going to talk about antibiotics first. There is no antibiotic that only kills the pathogenic strain. Thus, colonic health and immune health suffer. Jeff Thurston. We put it in our talk because we're going to talk about it in September. And that is so beautifully said, right? Any antibiotic doesn't just kill just the pathogen that it's going after. It completely has the opportunity to disrupt the entire microbiome, right? And we know that the microbiome is 70 to 80% of our immune system. So, and the majority of the antibiotics that are written as of 2016, 270.2 million prescriptions for antibiotics were written as per the CDC. That's enough for every 5 out of 6 Americans in the United States.
Yeah,
so
a lot of cattle and a lot of other things, right? So
isn't that something? That's exactly right. And not every antibiotic written is actually, written for an infection or even what it's needed for, right? So we do overprescribe quite a bit, and Kirsty sees that. So, and yes, the microbiome is affected, and it's going to deplete so many minerals, your zinc, your magnesium, some calcium, your B vitamins, vitamin K. What else, Kirsty?
I think you have our notes, don't you?
Do I? Well, I do have some.
Well, I think,
notes.
look, I think antibiotics is like a really obvious example, and I'm glad you shared that.
You bet.
It's still critical. But I'd love to just understand, like, what about these other drug categories? Like, what are they doing to the microbiome, and what, what are the knock-on effects of that?
I would say that, let me pause you there though. It seems like antibiotics would be obvious, right? But your conventionally trained clinicians have no idea of like the long-term impact of a course of antibiotics. Like, I was not taught that in school. So a big component of my job as a clinical pharmacist is antimicrobial stewardship, right? And so I'm passionate about the appropriate use of antibiotics, and that antibiotics do save lives. There's no doubt in that they do save lives. But I was never told that a course of antibiotics, correct me if I'm wrong, but I think the statistics are, but one course of antibiotics can disrupt your microbiome, I think, for up to 2 years.
Mm-hmm.
Yeah, that's right.
Yeah.
And so clinicians just aren't taught that.
Course.
And they aren't taught how to course correct. So they aren't taught that, say, your patient comes in with like a life-threatening infection that they need antibiotics for. What can we do to help remediate that? What can we do to help plug the holes of what happened? And so they may know about probiotics, but they may not know which probiotics the patient needs, okay, based upon the gut bacteria that were killed. And that's a whole other conversation because that's huge. And they may not know about the timing of probiotics, that you need to separate them from the antibiotics. So that's just something, I feel like, a little caveat that's important to point out, that while it seems so obvious to those of us in functional medicine that antibiotics literally anti-life, it's killing things, your conventional prescribers are not aware of just how detrimental that can be. They know about C. diff, they know about things like that are side effects of antibiotics, so they don't know about the other little things that may be missed.
Well, one thing I saw recently that was really shocking was that, I think it takes 2 years, to come back. But ultimately, like if you looked at the number of courses of antibiotics, like in early life, you maybe never made it back, right? You never caught up to a full microbiome. And then, that was sort of like some of the drivers of these chronic pediatric issues. Where, if you look back when I'm friends with some, functional medicine pediatricians, and it's like every time you get these really chronic cases and no one can work out what's going on, you do the timeline for the first time, you ask about antibiotic use, early in life, and it's always like heavy and regular.
Well, you think about a cesarean section delivery, right? The mom's given antibiotics for the procedure. The baby's not delivered vaginally, so they're not getting that exposure to the vaginal microbiome. So they're not getting the population for their gut bacteria. And then it seems like that just kind of rolls along throughout their life.
Wow. Yeah.
Sure does.
Yeah.
So then, so do you have any other information from your presentation and so forth on like other categories of drugs and how it affects the microbiome?
Yeah. Well, we have NSAIDs, we have corticosteroids, birth control. Pick your poison. Which one do you think?
Let's start with NSAIDs then, because I know that's like America's favorite drug.
It sure is. More than 30 million Americans use NSAIDs on any given day in the United States.
Wow.
Unbelievable, right? I don't know the last time I had an NSAID, and they are great for acute inflammation. They are, but they can actually, when used long-term, they become pro-inflammatory, and they're going to disrupt the microbiome. For sure, they're going to deplete vitamin C and folic acid and iron and B5 and calcium and really open up those tight junctions, which are going to cause heartburn and GERD and increased risk of Crohn's, right?
Yeah.
Crohn's?
GI bleed. Crohn's. These are things providers know. Yeah. Crohn's, GI bleed.
Absolutely. Heartburn and, stomach ulcers, which you all preach all the time and educate on at the pharmacy. Actually, diarrhea, increase their diarrhea, and homocysteine levels, chronic inflammatory markers increase.
When I was researching, like just for de-prescribing for that part of our conversation earlier, NSAIDs were one of the drug classes that were targeted, like chronic use of NSAIDs.
Really?
Mm-hmm.
So, in that situation, so let's say you've got someone who's taking them. Why are they taking them, right? They're having some sort of low level pain, right, that they want to work with. Yeah. So if you have someone who wants to come off their NSAIDs and you want to try and get them out of it, what are some strategies that you use from your functional medicine toolkit to, help with the pain? Is it a case by case basis? Is it a root cause approach, or are there some other things that you've used to, to help while you can, move them along?
Yes and yes. Okay. It is case by case, and it's root cause. And we start with what's at the end of their fork always. And again, stress, but always an anti-inflammatory diet. Gluten, dairy, sugar, soy, corn, eggs, and peanuts. There's your top 7 inflammatory foods right there. So we start with that, the diet, the stress, the sleep, and all. But then I use, in my practice, I use a tremendous amount of turmeric, curcumin, anti-inflammatory things like that. CBD, fish oils, any of those anti-inflammatories. I'm trying to think. Oh, yeah. Well, pro-resolving mediators, SPMs. I use a tremendous amount of, I don't know if you're familiar with that, which literally ibuprofen, Tylenol, things like that. They literally block inflammation, which is what keeps a low level inflammatory response through your body. Always. It never really resolves the inflammatory response, the joint pain or the headache or whatever you have going on. Pro-resolving mediators literally act like, well, they're macrophages that eat the cytokine inflammatory response, and they literally resolve the inflammatory response. Pro-resolving mediators, specialized pro-resolving mediators, we've known about for about 20 years. Dr. Sirhan at Harvard discovered those. We've got study after study on pro-resolving mediators, how they literally eat the inflammatory response. It's fascinating. It's the number one thing I've used the last 2 years in my clinic with COVID. Is the only thing that took my headache away were pro-resolving mediators. And it is incredible. Our bodies have them endogenously, but what we've learned is people with chronic inflammatory response have lower levels of pro-resolving mediators in their body. They're made from arachidonic acid and EPA and DHA, but there's a lot of steps in between there that can happen that can mess that up. So huge diet and then a few supplements for me is how I address it. What about you?
Yeah.
Same kind of ideas there.
Yeah, those are great ideas. I like
awesome. Well, look, that's great. I'm glad we got to look at that. Let's get on to the next one then. Let's talk about corticosteroids. So again, popular, but slightly different. So what's the mechanism of what's happening there with the corticosteroids, and what nutrients are they depleting and how they're affecting the microbiome?
Dani, I think you have our notes. I don't have those notes.
Oh, well, depleting. Corticosteroids are going to decrease inflammation, which, we originally were not going to talk about this, but then with COVID, we've had just a resurgence, right? I mean, are you seeing this in the pharmacy, or before you were, when you were working in the pharmacy, of a resurgence of steroids, right? At this point. So again, they open up those tight junctions and create a leaky gut and disrupt that entire microbiome, but also increasing your risk of gastritis, peptic ulcer disease, abdominal distension, dyspepsia, elevated blood sugar, huge. We all know that. That's common sense, or we were taught in school. Weight gain, osteoporosis, which is what I deal with a lot
long-term, right? Long-term use.
Long-term use of osteoporosis, yes. But nutrient-wise, they're going to deplete, things like calcium and D3 and magnesium and zinc and vitamin C, all your B vitamins, your folic acid. They also are going to delete selenium, which is real important for our thyroids long-term, and chromium. So supplement-wise, I mean, again, it's very similar to what we would do for NSAIDs, decrease the inflammation in the body. Things with like fish oil and turmeric and CBD. I'm a big fan of a really good CBD, working on the endocannabinoid system there. Kirsty, what?
Yeah, no, I just think it's important, obviously we're talking to providers, but I mean, we realize that patients are likely not using these just acutely, like with NSAIDs or with the corticosteroids. I mean, throughout COVID, we saw corticosteroids were kind of the first line treatment, both inpatient and outpatient, for patients who have been diagnosed with COVID. But patients are using these for years and years on end, patients with rheumatoid arthritis and all the other, especially autoimmune patients, tend to be the ones who get prescribed corticosteroids because the physicians don't know what else to do for them. They know that there's something inflammatory happening. They don't know how to stop it with food or supplements. So corticosteroids are kind of the Band-Aid that the patient gets, but corticosteroids are probably one of the more dangerous medications to be on long-term. As far as like adrenal suppression, osteoporosis risk, yeah.
Peptic ulcer disease, I think, is increased by 4 times when used in conjunction with an NSAID. Is that correct? I think that's correct.
Yes,
In fact,
so.
I believe it's correct. I know. Also, capsaicin, James. I forgot about that. Capsaicin is one of the things that we also use sometimes that as an alternative to a steroid. It really brings down inflammation. But I have a lot of patients, autoimmune patients, who are on long-term steroid use, and it's heartbreaking. I mean, young women in their 30s who now have got osteopenia, moving right on into osteoporosis. And now they're dealing with, they're on the verge of type 2 diabetes as well with their blood sugar levels. So anything that we can do to bring down inflammation. But one thing about corticosteroids, James, we forget that inhaled steroids, nasal steroids, even topical steroids, they all have that same mechanism of action, and they are disrupting the microbiome.
And those are available over the counter, right?
Yes.
So fluticasone nasal sprays, your hydrocortisone ointments and creams. Those are things that providers.
They're systemic. So they're going to deplete nutrient, you're going to have nutrient depletions from that and a disrupted microbiome. Every single thing with NSAIDs, corticosteroids, birth control, proton pump inhibitors, we have to replace what it is that we are depleting.
Yeah,
and
absolutely.
It starts with the diet, always with the diet.
That's great. Well, let's jump into that. You mentioned, women in their 30s. Obviously, one of the things that we talked about here was oral contraceptives. I've definitely seen a little bit of a backlash online happening from certain people recently, just being like, how are these contraceptives being prescribed for such a crazy range of conditions?
Well, that's it, right? Most of them are prescribed for things that aren't for birth control.
Yeah.
I had a patient today. Her daughter is 15 years old, and I've seen her for a long time. And she said, Dani A is wanting to start birth control because her periods are terrible. She's horrible cramps. And I said, really? I said, well, it's not a birth control deficiency going on there with her. I said, why don't we figure out, I said, is she having sex? Oh, Lord, her mother nearly had a heart attack. And she said, no, she's not having sex. I said, well, then I'm not so sure that she needs it. So, yeah. So birth controls do disrupt the entire, my God, what are you going to say, Kirsty? You're wanting to say something.
No, I mean, that was me. That was me. I was started on birth control at 15 years old because I had acne.
Yeah.
I was started on actually doxycycline. Let's go back to the antibiotics. I was started on doxycycline and birth control. But anyways.
Probably not a recipe for resilient health.
And I ended up, with Hashimoto's. So wonder how that happened.
Yeah,
that's right. And the longer you're on an birth control, the greater your risk of depression as well. I can't remember twice as high your risk of depression is. And one of the big ones is, birth control depletes B6 and it depletes zinc, and it's going to deplete your B vitamins, actually most of your minerals it will, as well as your beneficial flora in your gut. So, here's the big one though. And you got to weigh the risks and benefits with this, James, for sure. This is a big one because, do you want a baby? If you're having sex, and moms and parents don't want to hear this, you have to weigh the risks and benefits. And you tell a teenager, to abstain at college, maybe they will, maybe they won't. I don't know. I don't know the answer to this. We honestly don't know we don't know the mechanism of action on how it depletes the nutrients in your microbiome, but it does. And I'm a big believer that this is something you got to talk hard with your people about. And, it can also cause infertility being on birth control for an extended amount of time. So natural family planning is of course the key there, or some sort of non-hormonal birth control.
Yeah.
Like copper IUD or something, but
you bet.
But here's the thing is that, recently our Supreme Court reversed some laws that have been longstanding. And so now there's this big push for everyone to have access to oral contraceptives, right? And there's a big push for, I think I saw recently something for them to go over the counter.
Oh.
Yeah.
I didn't see that.
And, regardless of your viewpoints, on that whole situation, it still stands that who is going to educate these young women on potential side effects, right? So it's one thing to be on, birth control short-term for birth control, for contraception. You can plug some holes, but I feel like the majority of women get started on them at a young age, and then they stay on them until they're ready to have children, and they try to come off of them and realize we have a problem.
Yeah. I've said that so many friends, especially, living in New York and LA, where everyone would have kids later. And then, 35, 37, 39, 41. And now it's suddenly like, there's been some downstream effects to the choices that I've been making. And then that's a heartbreaking moment, at that time too.
Yeah. And not even, it also can impact your mate selection. Have you all seen those studies? Yeah, it's very interesting that it can disrupt who you choose as a mate.
By
so choosing someone,
right? By pheromones?
Yes, via pheromones. I think it's like an MHC complex is actually the name of it, but you end up choosing a mate that's more like you than dislike you. So, perhaps that has something to do too with fertility. Like it's layers upon layers, and, we're going to find out, I think, way down the road that.
Yeah. Well, the environmental insults are many. Look, I guess I want to ask you from a practical point of view, now you're like taking a patient in and you're doing like your functional medicine timeline. How do you weigh, how do you sort of go deep into really discovering, how long have people been on what drugs? And then, in your mind, sort of assessing how that's affecting their health today. Like how much weight do you put on this when you're doing your intakes?
Dani,
I put a
do a timeline. Don't you do a timeline?
Yeah, we do a timeline.
I'm Dani's patient, so I let people know that.
From a functional medicine point of view, when you do the timeline, how important is their drug history to your timeline?
Yeah. Well, it's extremely important to my timeline. And then what else is also extremely important, which ties in with the drug history, is your childhood trauma, your adverse childhood experiences in that timeline, and that which can also, affect what the drugs you're taking. So our timelines are very detailed, and it is very important. Yes. And so when you address the trauma, when you address the pharmaceuticals that you're on, and then the timeline in that, it's all connected. And then sometimes when we treat the trauma, guess what happens? Your body starts to release and heal, and it's easier to de-prescribe some of these things. Right, Kirsty?
Yes, but that's something that's really one thing that I wish that Western medicine would recognize more than it does, because have all these, we were talking about NSAIDs, we were talking about corticosteroids, we didn't talk about opioids, but we have all these chronic pain patients. And what do we know about chronic pain patients? It's almost always a history of trauma.
You bet it is. You bet it is. I spent 24 years seeing doctors, but the first 18 years of my life was suicide. My grandfather, my mom attempted. I was molested by one stepfather, beat up by the next, 4 colonoscopies, chronic diarrhea, put on every drug known to man in 24 years of seeing doctors from 20 to 44. Not one time was I asked by a healthcare provider, 4 gastroenterologists, Dani, what's your stress like? What was your childhood like? If they had ever asked that, then we would have known where it started. The root cause right there.
Absolutely.
You bet.
Well, look, I want to just sort of tie this up a little bit, because obviously we have coming up here the event that you guys are speaking at, which is actually in Nashville this year.
Yes.
A short commute for you, Dani. Maybe you don't even have to stay at the hotel.
Oh, I'm staying at the hotel. I'm a single mom. I don't ever get to the hotel. So I'm staying at the hotel.
Well, yeah, I'm coming on that. So that's the 24th of September. It's the Functional Pharmacy Symposium. But I just wanted to share here. So, coming up soon is, we have these functional forum communities. And the whole point of these communities is for a safe place where practitioners like you could invite other doctors who are just sort of like, that endocrinologist that referred someone to you, right, Dani, today. Like that's the person that you would invite, because you're like, hey, obviously they know that something's working. Let's bring them a little bit further into the fold. And so, the purpose of the functional forum communities is always to create community, to make it an easy place for clinicians to come together and learn about these kind of topics. And so we do have one happening in Nashville. I think it's going to be brought together here by Metagenics. But here is, if you go to functionalforum.com, you can go and you can check out the different communities. You can see the upcoming events. We're hoping to have an event at every one of these communities in August, September, October, so that we can kick these groups off. The conference is happening there in Nashville too. That's on the 24th of September. There's a lot of exciting, I guess Nashville is the medical center of the country in a weird way, with the HCA and so forth there, like it's the center of the universe. I guess even more important that we can infiltrate in there, right, Dani?
Absolutely. Absolutely. Yeah, it's exciting. So I can't wait till you get to Nashville. And, it's just bringing one into the fold, like you said, one at a time. All it takes is one. You know, the endo that sent her today, she doesn't really believe in what I do, but she knows enough to know that she doesn't know. She's really not wanting to learn about it yet, but she knows someone who can help this person, you know, and that's huge because a lot of people don't do that. And like JJ always says, a rising tide lifts all boats, you know, and it's true. So what you're doing is great work out there, and I'm proud to be a part of it.
Thank you. And Kirsty, I guess for you to go back now to your like mainly pharmacy colleagues and talk to them about what you're learning. I mean, I found it quite an inspiring group to be part of the last 2 years that we've been. One, because you know, there's just a lot of like that kind of initial exciting, you know, piece that was really, really excited. There's sort of like so much excitement about the potential of having some other tools, but also just, you know, finding community with other pharmacists that are seeing it the way that it is. You know, how excited are you about showing up and having those kind of conversations with some of your colleagues?
Yeah, I'm so excited. You know, pharmacists really are on the front lines, and I feel like many of them are eager to find other ways to help their patients besides just, you know, dispensing medications. And so this is really an opportunity for them that's well within their scope of practice, because pharmacists tend to be a little bit more risk averse, I feel like, maybe than other professions. But this is something that they can learn about, that they can do, that they can incorporate to help their patients every single day. So it's really exciting. And I always tell them, you know, these are things, I'm not gonna say they're harmless, but these are things that don't carry as much risk as some of the medications that you've been dispensing for years, right? I mean, magnesium, just multivitamins, things like that. So learning about those things can just really change your patients. And nutrition, my gosh, I mean, that never hurt anybody, right? Like eating better never hurt anybody. So if you can give them that type of advice, yeah, I'm looking forward to it.
Well, we have to empower the pharmacists to be able to be the one on the front line, because, you know, again, if the family practice doc or the specialist is not doing this, then it's the pharmacist who is on the front line, right there with that patient, saying, you know what, this Nexium could deplete your, you know, or block your stomach acid, which it probably is. You may need more stomach acid, or, you know, this metformin you've been on for 12 years is probably depleting your vitamin B12. Let's start you on a B12. Yeah. I mean, so if the pharmacist doesn't do it, who is? There's way more pharmacists probably than functional medicine providers out there. So until it all catches up, I'm so excited to be a part of it, James, the pharmacy conference, because I'm the only, well, I guess Dr. Pedro is not a pharmacist, he's a provider, but we're the only two that are not pharmacists speaking.
But what carries more weight though than your pharmacist, who is your drug expert? The drug expert is literally sitting here telling you, this is going to cause this problem, this is what we need to do about it. So the person who's supposed to be the most pro medication is telling you that your medication may be causing you a problem.
Yeah,
that's right.
Well, that's part of the reason why I've gone the last 2 years, because I saw exactly what you just said, Kirsty. I saw the potential for a movement amongst providers that are like really on the front lines and maybe don't have, you know, maybe are a bit more open, you know, to thinking about things in a new way. Obviously, it's exciting to see doctors and providers coming in this direction, but like for the kind of change that I think we can all see is needed to really create health in the American system, you know, we need everyone along for the ride. And it's not just America, it's Canada, it's the UK, it's Australia, it's everywhere where we have this pharmaceutical first approach to medicine right now that is not working for the majority of chronic illnesses. And so, you know, it's going to take a team of us to make it happen. So I guess I just want to, you know, finish by saying I'm so grateful for both of you. You know, we've had different kind of formats of the Functional Forum over years, like sometimes the conversation, we have presentations, we have stuff from conferences, but like, I really appreciate both of you just being real about what it's been like in COVID and what it's like to treat these kind of patients and doing it. I think, we're ready for these kind of real conversations now. And I want to be able to host these kind of real conversations here at the Functional Forum, because ultimately, I know that your experience is not unique, and I think a lot of people have been feeling and experiencing it, but it's been a sort of a traumatic event in its own right. And so coming out of it here on the other end, we can think about how we can use this momentum to do better. So thank you so much for being part of the Functional Forum. We'll be back in 6 weeks. It's the second week in September, because the first Monday is Labor Day. So we'll be back in 6 weeks. Hope you can join us then. Thank you so much. We've had Dani Williamson here. She's a nurse practitioner. You can check out her website and her book and her 6-step methodology. And she is seeing patients in Franklin, Tennessee. And Kirsty Washam is a clinical pharmacist. And we're really grateful to have you here. Check out the Fed-Up Pharmacist on Instagram. You can check her out there. Thanks so much, everyone, for tuning in. This has been the Functional Forum. I'm your host, James Maskell. And